nephron, and then we're going to work our way through that. So we have the thin descending limb, right, of the comes all the way up. Distal convoluted tubule, and that will continue with the collecting, right, duct. All right, renal pipeline. Okay, good. So starting with, and we have our blood vessel here, afferent arteriole, right? They come in, and then efferent arteriole is leaving. It continues here. All right. Okay. All right. So, so starting with, so first of all, right, one of the hormones that will work here is going to be prostaglandins, right? So we know prostaglandin is going to work also here, and right. So prostaglandin, what does prostaglandin do? Where does prostaglandin work here? It dilates the afferent arteriole, right? Dilate afferent arteriole, right? Yeah. So prostaglandin will dilate afferent arteriole. So basically, it helps. If I dilate afferent arteriole, what will happen to renal blood flow? It's going to increase, right? It's going to increase renal blood flow or renal plasma, right? Flow, yeah. And if I increase renal blood flow, renal plasma flow, what would I do to GFR?
It will increase also.
So I'm going to increase GFR. Thank you very much. Yeah. So, right. So people, right. So this is important, right? This is why NSAIDs are what? Are nephrotoxic, right? NSAIDs can cause AKI.
Yes.
And eventually chronically, right, it can cause CKD, right? Because NSAIDs will inhibit prostaglandin. If it inhibits prostaglandin, what happens? Yeah, that will decrease renal blood flow, renal plasma flow, which will decrease what? GFR, right? Yeah, and that will decrease urine output, and you're gonna see creatinine BUN, right? Will start becoming elevated. So that's gonna be there. Another thing with this is, you know, loop diuretics, right? Like furosemide. So we know loop diuretics actually have two mechanisms of action, right? The first one is they can increase prostaglandin release. You get it?
Okay.
Loop diuretics like furosemide, they can increase prostaglandin release, which will increase renal blood flow, increase GFR, and also what they can also, we know they work at the thick around this area, right? At the thick ascending limb of Henle, and they're gonna inhibit sodium potassium chloride cotransporter, which will further increase diuresis, right? So by doing this, right, so having two mechanisms of action, which means that they have a greater diuretic effect compared to other diuretics. Yeah. So patient taking, if I give you a scenario, so there can be, so this can cause a lot of drug-drug interaction, right? NSAIDs, they can counteract the effect of loop diuretics. Does that make sense?
Okay. Yeah.
If somebody is taking loop diuretics and they're taking NSAID, you might see decreased efficacy of the word of the diuretic, loop diuretic, because of what NSAID will inhibit prostaglandin, which will block one of the mechanisms of action, right, of diuretics, of the loop diuretics. Does this make sense? You get this? Yeah. So that's gonna be okay. One. All right. Two. All right. So let's move to the second one. Two is gonna be RAAS, right? So the RAAS pathway. What is the starting point of the RAAS pathway, right? So the problem with that, what's the signal that will trigger RAAS? If there's decreased renal blood flow or decreased renal plasma flow, what happens to GFR? GFR decrease, right? So there will decrease amount of sodium and also especially sodium, right, that will be filtered into the renal tubule. So which means most of the sodium will be reabsorbed, right? Probably in the proximal convoluted tubule. Does this make sense? So there will be little amount of sodium that will get all the way to the distal. And at this distal convoluted tubule here, we have, right, our macula densa, right? Yeah, around this location, which is gonna be like there's a physical interaction between the DCT and the afferent arteriole, especially. So it's gonna trigger the macula densa. If we trigger macula densa will trigger the juxtaglomerular cells, right?
Okay.
So macula densa will sense the low sodium, urinary sodium. It's going to trigger the juxtaglomerular cells. What do? They're going to release what? Renin. Good. So when they release renin, what will renin do? Renin will go to, so renin is going to do what? Convert angiotensinogen, right, to angiotensin 1, right? Which cell, which organ releases angiotensinogen? The liver, right? Yeah. So liver normally makes angiotensinogen, right? So renin will convert angiotensinogen to angiotensin 1, and angiotensin 1 will now go to the what? In the lungs, right? It's going to be converted by ACE, and then converting them to what? Angiotensin 2. Does this make sense? Awesome.
Yes.
Okay, good. Now, and angiotensin 2, what does it do? Where will it work? First, there's a vascular, right? It works on the vessels. Yeah. And which receptor will angiotensin 2 use? Yeah, it has like two major receptors. I think angiotensin 1 and angiotensin 2 receptor. So the angiotensin 1 receptor is going to be the one, I believe, that is on the blood vessels, right? Vascular, that will cause vasoconstriction. Right, and it does this both directly and also what it can induce endothelin release. You get it? So works on the endothelial cells. They're going to release endothelin, and also through direct effects, we're going to see vasoconstriction. Right, so this will kind of help us bring up blood pressure. Awesome. Another thing it does, right? So it goes to the kidneys. When it gets to the kidney, right now using angiotensin receptor, right, type 2. What we're going to angiotensin 2 receptor in the kidneys. So there's a place where it's going to work. There are two places going to work in the kidney. So the first thing is that what it's going to constrict, right? It's going to cause vasoconstriction of the efferent arteriole.
Yeah.
Thank you very much. It's going to constrict, right, efferent arteriole. Yeah, AG2. When it constricts efferent arteriole, what do you think will happen to renal blood flow? So we're looking at the effect of AG2 now on the efferent arteriole, right? So it constricts. You said?
It will increase.
It's going to decrease, right? Renal blood flow, because we now have like a back pressure. Does this make sense?
Okay.
Right. If I constrict this one, so there's like a gate. Do you get it? So that will create back pressure, right? There'll be back pressure. So that pressure will impede the movement of blood, right? Coming into the what? Into the key glomerulus, right? From the afferent arteriole. Does this make sense? You get it? Yeah, because of that downstream resistance. So our renal blood flow, renal plasma flow, right, will go down. But what will happen to GFR? GFR will go up. Why? Because of what? If because of the downstream vascular resistance, what happens to your hydrostatic pressure in the glomerulars? It's gonna go up. Good. The glomerular hydrostatic pressure goes up. So that pressure will push more, right? Plasma, right? Into the what? Renal tubule. We're gonna filtrate more molecules, right? Right. So our GFR will go up. What will happen to filtration fraction, which is basically what GFR, right? Divided by RP, renal plasma flow. That will go up. It's gonna, yeah. So remember, GFR goes up. This guy goes down. What happens to this guy? It's gonna go up, right? Yeah. Filtration fraction will go up. Does this make sense? We get this?
Yeah.
Okay, awesome. Good. So that's gonna be that. This is the reason why, right? So let's say somebody has renal artery stenosis, right? So imagine there's renal artery stenosis. So there's an atherosclerotic plaque right here that is limiting the amount of blood flow. Does that make sense? Into the what? Into the glomerulus. If someone has renal artery stenosis, which means the renal blood flow goes down, they have decreased filtration, there will be what? So this will activate RAAS, right? Because less sodium will get to the DCT, macular denser will sense it, activate RAAS. So angiotensin will cause vasoconstriction, and this is going to be beneficial. If I have decreased blood flow coming in through the afferent arteriole, but angiotensin 2 constrict the efferent arteriole, right? It's going to create what? Increased hydrostatic pressure here, and that will still be able to maintain, do you get it? Filtration, right? GFR. So these people's BUN creatinine will still be kind of normal, right? Because you're still able to maintain, right? Hydrostatic, create hydrostatic pressure that will maintain filtration through the glomerulus, even though we are bringing in less blood, right? Through the what? Through the narrowed, right? Artery. So, and this is what in people with bilateral renal artery stenosis, right? ACE inhibitors ARB are contraindicated. Does this make sense? Right? Because if you give them ACE inhibitor ARB, right, and it's exactly, it's going to eliminate the effect of what? Angiotensin 2 on the efferent arteriole. And what will happen? We're going to lose that hydrostatic pressure, and our GFR will drop. So these people's creatinine and BUN will double, right, on starting with the ACE inhibitor ARB. Does this make sense?
Yeah.
Clear?
Yes. Yeah.
Very clear.
Mhm.
Okay, good. Where else will angiotensin 2 work? Angiotensin 2, right, also works on the at the PCT. Yes.
Yeah.
Angiotensin 2 works at the what? Proximal converter tube, right? It's going to stimulate what? Sodium co-transporters.
Right.
Right. Remember, how do we absorb sodium at the PCT? If we use co-transporters, right? Sodium phosphate co-transporter, right? We have sodium glucose co-transporters, or the SGLTs, right? Basically, the sodium co-transporter, sodium SGLT2. We have the sodium phosphate co-transporter. We have the sodium amino acid co-transporter, right? That's how we absorb sodium, right, at the PCT. Does this make sense?
Yeah.
So
Yes.
if somebody has volume contraction, a patient is very, very dehydrated, volume contraction, they're hypotensive, we activate RAAS, we want to maintain, right, volume, right? So angiotensin 2 is going to, right, stimulate these channels here at this at the PCT, and that what is going to increase sodium reabsorption, right, at the PCT, which means water too will follow, right? So basically, this will help us maintain, right, the volume. Does this make sense? Yeah.
Yeah.
You can use this, right? You can take advantage of this in patient with diabetes insipidus. You can take, because of this principle, you can take
Yeah.
advantage of this, right, in treatment of nephrogenic DI,
Okay.
right? So in nephrogenic DI, right, you're gonna treat the patient with thiazide diuretic. What do thiazide do? Thiazide diuretic, they're gonna decrease, they're gonna cause volume depletion, right? Yes. The patient becomes slightly dehydrated. Does this make sense?
Yeah.
Because thiazide diuretics will inhibit, like, they're going to work at the DCT, and patient will be losing, like, there'll be a lot of, and you're going to be thinking, isn't this counterproductive? Patient has NDI, they're already losing a lot of volume, right? Water, because the kidneys cannot concentrate urine. Why am I giving them diuretic again? But by giving them thiazide, right, patient will be losing sodium, right? They lose sodium and they lose some water, right?
Yes.
So
Yes.
this will trigger what? It's going to activate RAAS. Does this make sense? Yeah. If it activates RAAS, angiotensin 2 will work on what? At the PCT. Angiotensin 2 will work at the PCT, and it's going to what? Increase sodium and water reabsorption. So what happens is that what? You are increasing the proximal reabsorption of sodium and water before the water gets to the what? To the loop of Henle, right, and go to the distal part of the of the nephron, right, where there's no ADH, right, and we're going to be losing a lot of the water in urine. Does this make sense? You get the
Yeah.
principle? Yeah.
Yes.
So this basically decreases the volume of water that will be lost, right, in urine in those patients by increasing the proximal reabsorption of what? Of
Yes.
sodium and
Sodium
water,
and water.
right, at the
Yeah.
PCT. Does this make sense? You get it? Okay, very good, right? Okay. What does the angiotensin 2 do? It goes to the what? Adrenal gland, right? Adrenal cortex, and it's going to what? Release aldosterone. Thank you very much. So we release aldosterone. Aldosterone goes where? To our collecting ducts, right? The principal cells in the collecting ducts. And in there, it's going to what? I remember, it's going to trigger what? The synthesis. Remember, aldosterone is a steroid-like, is a steroid hormone, right? So it's going to enter the cell membrane, enter the cytoplasm, enter the nucleus, and it's going to what? Bind to it what? Response element, right? Binding protein, and trigger the gene for what? Epithelial sodium channel.
Okay.
Awesome. ENaC, right? And we're going to place ENaC in there, and what will happen? There will be what? Increased sodium reabsorption. And what will be lost as sodium is being reabsorbed?
Potassium.
Huh?
Potassium.
Potassium will be lost. What else will be lost? What does the aldosterone do at the collecting to duct? There's another ion that's going to increase its secretion, which will be what? Hydrogen ion, right? Right?
Yes.
Right. So aldosterone will stimulate the the type A intercalated cells, right, in the collecting duct, and that what is going to increase. So in this case, it's going to be increasing potassium and hydrogen ion what? Secretion, right? Right? Or excretion from the body. Does this make sense? You get this? Right. Yeah. So this is where, right? This is where you acidify urine. Do you see what happens here? At the DCT, right? This is where we are acidifying urine. We're going to be adding hydrogen ion, right, to the urine and the DCT, right? So this is where we acidify urine. So if anything happens to the DCT, right, or a patient has hypoaldosteronism. What do you think will happen? Their urine will become much more alkaline than usual, right? That's what you're going to see in what? In type 1, right? And type 4, renal tubular acidosis. Type 1, where there's what? There's damage to the DCT, right? Distal convoluted tubule. So the body cannot excrete hydrogen ion. So the urine becomes alkaline. They're going to have normal metabolic acidosis, and they're going to be hypokalemic. In type 4, there's hypoaldosteronism, either due to lack of renin or there's adrenal insufficiency. So the same thing, there will be hyperkalemia in that case, but still there will be no hydrogen ion excretion or secretion from the body. So that also causes what? The urine becomes alkaline. There will be non-anionic metabolic acidosis. Does this make sense? You get it? Good. So that's going to be that. So these are the, that's the RAAS pathway, right? And the ones that, and their function, right, on the kidneys, right? We got the location and the function, correlation, everything clear?
Yeah.
All right, good.